So good afternoon. Thank you so much for having us today. I'm Arunima Basu, and I'm here with my fellow medical students, Siddhant Patki and Morohunfoluwa Bajomo. So before we begin, we'd also like to thank our supervisors, Dr. Lourdes and Dr. Antonio Neto, for their guidance and support. So today we're going to be presenting an economic evaluation of vaginoscopy versus traditional hysteroscopy for uterine examination. As we all know, hysteroscopy is a really common gynecological procedure used to examine the uterine cavity. Whilst the traditional method of hysteroscopy involves using a speculum and/or forceps, vaginoscopy, or the no-touch technique, doesn't require such vaginal instruments due to the use of small diameter endoscope. Outpatient hysteroscopy is considered to be the gold standard method for uterine examination. The National Institute for Health and Care Excellence, or NICE in the UK, recommends vaginoscopy as a standard technique based on trials that showed that vaginoscopy led to greater clinical outcomes. But prior literature has highlighted that clinicians are still using the traditional method of hysteroscopy. We conducted a literature review using 3 databases to identify clinical studies and cost-effective analyses, comparing the 2 techniques. The search found 5 randomized control trials and 1 retrospective cohort study and no economic evaluations. 5 out of the 6 randomized clinical trials found that vaginoscopy led to less procedural pain and shorter procedural duration than standard hysteroscopy, again supporting the use of vaginoscopy. However, there was a lack of trials that compared the post-procedural complications between the 2 techniques. The VAST trial. It was the only identified randomized control trial that has recorded such data in the UK. The findings from the trial illustrate that vaginoscopy resulted in fewer post-procedural complications, shorter procedural timings, and more successful procedures. Although the VAST trial concluded that vaginoscopy was the superior technique from a clinical standpoint, the direct and indirect costs of the procedure weren't taken into consideration. Differing complications and the costs of managing them may result in overall differing costs in the long term. As a result of the findings, it is not immediately apparent whether vaginoscopy offers a cost-effective alternative to traditional hysteroscopy. So the need for an economic evaluation to be carried out can be justified to evaluate the costs and benefits of the 2 procedures. This would help to maximize the utilization of scarce health resources, as well as establish whether it is cost effective. Therefore, the objectives of this study was to perform a cost-effective analysis between vaginoscopy and traditional hysteroscopy as an investigative procedure for uterine examination. And the data used was from the VAST trial, as it was the only paper identified to report post-procedural complications.
So, in a cost-effectiveness analysis, the economic effectiveness of one intervention method, so in this case, the traditional hysteroscopy method, is compared to another similar one, so in this case, the vaginoscopy, by estimating how much it costs to get 1 extra unit of a given health outcome. This would help to ascertain whether an alternative intervention may be cheaper, but less clinically effective, cheaper and more clinically effective, or even less clinically effective and more expensive. In this evaluation, we defined that health outcome as procedural success, which was stated to be completion of the procedure with the full insertion of the scope device, with no infection, no complications, and an acceptable level of pain as defined from the VAST trial, where we obtained all of our data. The effectiveness with relation to cost, in this case, referred to the benefit gained from avoiding complications, excess pain, and infections from a successful procedure. The time horizon in an economic evaluation refers to the length of time for when health outcomes and costs are calculated, and is a key factor for modeling and analysis. For this evaluation, we chose a 2-week time frame for 2 reasons. Reason 1, being the VAST trial from which we obtained our data, utilized this 2-week time frame to mark the endpoint of recording the patient's complications related to the procedures. And so naturally, this made sense. Secondly, we felt, given the relatively short nature of the actual procedures that we were comparing, we wouldn't expect many patients to experience complications after the 2 week time mark. So the next phase of our study then involved establishing values for costs of each intervention, as well as the cost of the complications associated. So complications surrounding both procedures were sourced from the VAST trial and supplemented with some additional ones mentioned by the RCOG Hysteroscopy Complications Guidance. The complications we accounted for within this analysis included vasovagal reactions, cervical trauma, admission for analgesia, hemorrhage, UTI, so urinary tract infections, and vaginal discharge. All of our costs were expressed in British pounds and sourced from established UK national bodies, such as the British National Formulary and the NHS National Tariff. Given the cross-sectional nature of an economic evaluation, where a snapshot of time is being looked at, discounting is necessary to equate all costs to the same time value. We therefore used a discount rate of 3.5% in line with NICE guidance for health technology evaluations. And this was done on all the cost sources we got from years prior to 2022. So next, by taking into account all the direct and indirect costs of the two techniques, so vaginoscopy, traditional hysteroscopy, we carried out an incremental analysis to compare their effectiveness. A decision tree was constructed with the assumption that each outcome was mutually exclusive. As seen in the diagram, the structure of the decision tree was formed by two arms. Arm 1 referred to the vaginoscopy technique and all of its outcomes, and arm 2 to the traditional hysteroscopy technique and all of its outcomes. The primary outcome divided each arm into success and non-success, and subsequently, the secondary outcome defined the reason for the non-successful procedure, which fell into the categories of failure of the procedure, complications related to the procedure, and infections related to the procedure. From this decision tree, we obtained the costs of each procedural techniques with the probability, as well as the costs of the complications, infections, and non-successes, all factored into these cost values. This gave a value of £376.88 for vaginoscopy and £527.49 for standard hysteroscopy. The incremental cost effectiveness ratio, or ISA value, is the main output of an economic evaluation and helps summarize the findings. We use the following formula to calculate this ISA. The effectiveness values came from the probabilities of procedural success obtained directly from the VAST trials. So that was 0.891 in the case of vaginoscopy and 0.846 for the traditional hysteroscopy technique. The costs used in these formula were then obtained from the decision tree, as I just previously mentioned. So that was the £376.88 for the vaginoscopy and the £527.49 for the traditional hysteroscopy. This gave an ISA value of minus £3,346.90, demonstrating that an additional £3,346.99 was saved per successful procedure with vaginoscopy as compared to traditional hysteroscopy. This has been visually represented by Figure 1, which demonstrates that vaginoscopy was both clinically more effective in terms of the procedural success rate and incurred lower costs when compared to the traditional hysteroscopy. In addition to the ISA value, we also calculated two further summary statistics to represent the difference in impact between the two procedures: the monetary net benefits and the net health benefits. For these values to be calculated, a willingness to pay value also needs to be determined. We used a value of £9,000 as seen in both formulas. And this value was sourced from another UK economic evaluation, which compared the cost effectiveness of various other diagnostic techniques for abnormal uterine bleeding. Both of these statistics came out to positive values in favor of vaginoscopy, indicating the cost effectiveness of the vaginoscopy technique with willingness to pay of a healthcare system such as the NHS, being accounted for in these equations.
So, to ensure the robustness of our findings and to assess the influence of some of the assumptions that we made in our modeling, we carried out two methods of sensitivity analysis. In both cases, the conclusion drawn from the ISA values remained constant, with both values remaining in the same quadrant as previously seen in Figure 1. The first method involved thus altering our assumed management for the complication of hemorrhage and accounting for the indirect cost of this complication with this alternative management option. The costs of these management options were quite different, and hence we believed that there could be an overestimation or an underestimation of indirect costs related to the chosen management option. However, as previously mentioned, the ISA value was hardly affected. The second method of sensitivity analysis involved us using a model that accounted for missing complication data cases as the worst case scenario, rather than excluding these cases as we did in our original model. The worst case scenario modeling would overestimate the infection rates with vaginoscopy compared to traditional hysteroscopy. However, again, the ISA remained negative and within a similar range. So, overall, our model has shown that vaginoscopy incurs less procedural cost than traditional hysteroscopy. The traditional hysteroscopy technique was shown to have a higher initial upfront cost alongside a lower proportion of procedures achieving success. As a result, two factors increased: the overall number of complications and the severity of those complications was greater with traditional hysteroscopy. This led to greater costs in dealing with procedural complications and failures. In summary, as vaginoscopy was shown to be more clinically effective in terms of procedural success rate, alongside inducing a reduction in expenses, in comparison to traditional hysteroscopy, it was indicated to be more cost-effective. As this is the first economic evaluation that compares these two techniques, we are unable to compare the result to existing literature. The VAST trial itself was a randomized, controlled, multi-center trial performed in the outpatient hysteroscopy clinics in two UK NHS hospitals, Birmingham's Women's and Children's Hospital Foundation Trust and the Royal Derby Hospital. In total, 1,597 patients were enrolled in this study, producing a large sample size that increases the power and reliability of the results obtained. Coupled with the fact that this has taken place across the NHS in the UK, the results from this evaluation could be generalized across NHS trusts to further promote the use of vaginoscopy as a gold standard for outpatient hysteroscopy. Now, moving on to the limitations of this economic evaluation. One is the assumption that the outcomes are primarily influenced by the technique chosen out of the two. Since the VAST trial did not provide data about the doctors, the success rates of the procedures could be influenced by confounding factors, such as experience of the clinicians, rather than the technique of interest. Thus, further data on the clinicians performing other technique would help to identify other sources of error or complications. Another limitation of the trial was that it excluded women where it was known that cervical dilation would be needed based upon previous reports of severe cervical stenosis. The findings from the VAST trial highlighted that the main cause of procedural failing of vaginoscopy was due to severe cervical stenosis. Thus, the exclusion of participants with this condition could have led to a lower vaginoscopy failure rate in our model. As the cost of a successful procedure is less than a failed one, this would lead to reduced costs and increased effectiveness of our model. Hence, a percentile underestimation of our ISA value. Evidence suggests that vaginoscopy should be the standard technique unless it is known that cervical dilation for cervical stenosis is needed. The conclusions are also limited by the short time horizon used in this analysis. Since only a 2-week period was taken into consideration, any long-term complications from the procedure and the costs associated with it have not been accounted for. The assumed pelvic inflammatory disease could result in later complications, such as ectopic pregnancy and chronic pelvic pain. This would incur further future costs post our chosen time horizon. However, traditional hysteroscopy group experienced greater rates of PID, So taking these later complications into consideration will only strengthen our conclusion that vaginoscopy is more cost effective. And finally, this economic evaluation doesn't take differences of subgroups into consideration. Subgroups such as menopausal status can influence the elasticity of the female genital tract and thus potentially influencing the success of the method. While the VAST trial reported procedural success rates in pre- and post-menopausal, there was no breakdown of post-procedural complications provided for an economic analysis to be conducted. A more comprehensive study is needed to assess whether vaginoscopy remains cost-effective for all subgroups to develop more tailored recommendations. Now, the 2019 VAST trial provides strong evidence of the efficacy and tolerability of vaginoscopy over traditional hysteroscopy in uterine examination. This study finds that vaginoscopy leads to lower direct and indirect costs when compared to traditional hysteroscopy. Due to the increased cost-effectiveness of vaginoscopy, in comparison, this study adds further confidence to the body of literature already recommending it. This study is the first to support the use of vaginoscopy based on cost-effectiveness, so we recommend that further initiatives are implemented to ensure that physicians feel more comfortable with the technique and adopt vaginoscopy in practice. Thank you very much for listening to our talk today. We would like to take the opportunity to thank the Scholar Conference organizers for allowing us the opportunity to present at this event. If you have any further questions, feel free to email us at any of the following addresses.